Medical Education Manager, and I'm joined today by Dr. Joan Ingram, one of our medical advisors, and also Diala Smith, Belinda Ritchie, and Bronwyn Robinson, three of our immunisation education facilitators who are going to be assisting us in responding to your questions. So just a little bit of housekeeping to start with. If you look at the buttons at the bottom of your screen, I think we're all fairly familiar with webinars by now, but just in case. So just to let you know that the chat function has been disabled. So please put any questions into the Q&A area, and we will endeavour to answer them as we go, but we do recommend holding a little till towards the end to check whether your question is going to be answered in the webinar. However, at the end of the webinar, we will also allocate a length of time for you to put your questions in. If you would like to count this webinar as professional development, please download our reflection form that's on the webinar page on our website. If you fill in a little bit of a reflection and log the hour training that the webinar is, you can then put that into your portfolio for the nurses. Before we start this webinar, I'd like to acknowledge the very sad news announced yesterday of the death that is likely due to myocarditis linked to the COVID vaccine. I'm sure we would all like to express our deep sympathy to the whānau at this difficult time. And then to move on to some other announcements that have just come out relating to booster doses being given from 4 months. This is not something we'll be covering today. We have got a webinar on booster doses, and we are prepared to do a webinar in the new year. Just wanted to flag up that the booster doses from 4 months are not due to start until 2022. And I've just come off a meeting with people from the ministry. They are working on the practicalities of how to implement it, and also when the programme will start. So that will be communicated out to the sector in the normal way. So for the moment, carry on with your 6-month spacing, please. Lastly, I'm sure you'll be interested in the paediatric Pfizer, the vaccine for the 5 to 11-year-olds. The vaccine training will be available on our website probably by the end of this week. It will take about 90 minutes and includes a short webinar section on practical tips for communicating and working with children of this age range. This is partly because we're launching it over the Christmas holidays, so we're not able to do a live webinar for you to ask questions, but we will support it with a live webinar afterwards as well. There will also be a range of resources to support the programme, including labelling for all syringes, purple for the 12+, light orange for the 5 to 11-year-olds, and dark orangey red for the Astrazeneca, basically to match the caps on the syringes. Sorry, to match the caps on the vials, and the labels are supposed to go onto the needle guard on the syringe so you can still see the volume that's in the syringe and the colour. And so it will become a requirement that all vaccinations, all syringes that are drawn up are labelled, and these vaccine labels will come through from logistics. So you might notice in the toolkit it's saying all syringes need to be labelled. That will be as those labels come into play. It's just now we're getting 2, possibly 3 different types of vaccines being used at one vaccination site. It's become particularly important from a safety point of view. So this webinar is here to support you as a vaccinator with discussions around the risks and benefits of vaccination, so the informed consent side of things, and also to look at the latest information around myocarditis and the use of Astrazeneca and the risks of TTS and such like associated with that. So once Joan's gone through all her presentation on that, we will move on to some new resources around screening. And I'll finish off by talking to you about post-vaccination advice and making sure you're up to date with all the new resources from the ministry to support more informed discussions with our consumers post-vaccination and pre-vaccination, particularly around myocarditis. So I'm going to hand over with no further ado to Joan. Do you want to share your screen? I'll come out of my share. No, I can't. There we go. Sorry, Joan, that's my slow. There we go. So we'll just. Yeah. So Joan, you just, yeah, that's it. Perfect.
So first, I'd like to say well done to all of you. What a fantastic achievement to reach the milestone we have reached with 90% fully vaccinated, when you think the first doses were given in February and now 8 million doses have been given. So I think that is something to be really celebrated and acknowledged, a huge amount of work by so many people. And it's worth remembering that the vaccine started being used in the middle of December last year. And we're fortunate that we have data from a large amount of use of our vaccine in America, for example, where they've given 284 million doses of Pfizer. So it's very helpful to be able to watch the rest of the world doing the same process as us. So a quick update using data from the Australian Ausvax active surveillance system they have, where people are sent a text request to see how they're feeling in the days after the vaccine. And as you all know, the Pfizer vaccine is reactogenic, with people feeling fatigue and headache, etc., particularly after dose 2 here in green. And I just wanted to draw your attention that after booster doses, the local reactions are more common than after dose 2. However, the other systemic adverse events are about equivalent to after dose 2. On this side, you can see the reports from younger people, people aged 12 to 15 and 16 to 19. Again, blue is their first dose and green their second dose. And fatigue and muscle or joint pain are reported less commonly in this group than amongst the whole participants, but they do seem to report more feelings of fever. You can see 17 or 16% amongst these adolescent reportees versus 14% in the whole group after dose 2. So I think that's just something to maybe be aware of. The data about seeking medical care doesn't really differ amongst the adolescents compared with all ages. So after dose 1, fewer than 1 in 100 people seek medical advice, while it's just over 1 in 100 for dose 2 in all ages and adolescents, and similarly for booster doses. So that's kind of nice to know. So moving on to the main safety concern for the Pfizer vaccine, which is myocarditis and pericarditis. So from the US databases, as we know, the rate is highest amongst young people between 12 and 29 years, where it's 40 cases per million doses in males and 4 per million doses in females, and decreasing over the age of 30. Israel is again similar to us, where they've only used Pfizer with a 3-week interval, and they have reported 27 additional cases of myocarditis after 1 million people vaccinated overall, but again a higher rate in the 16 to 39-year-olds, where it is 86 excess cases per million people. And that compares with, from their data, 110 cases per million of myocarditis in people with SARS-CoV-2 infection. There's just a recent study from Denmark just been released, which is a very good methodology looking at their whole population, so perhaps more reliable than the US reporting systems. And their risk is even lower. They see a risk of 18 per million in the 16 to 39-year-old males. We do know that the risk varies by age and by gender, according to this American reports to their equivalent of CALM. So the highest rate here in this study is 16 to 17-year-olds, and it clearly dropping down after, but does continue up a little over 30 in this age, in this study. it is now become apparent just over the last few weeks that interval does seem to make a difference to the rates of myocarditis. So this is a study from Ontario, just looking at this side, which is looking at the Pfizer vaccine. Their rate of myocarditis per million doses was 50 in those less than 30 days. So that's 21 days, obviously. But after 8 weeks, the rate of myocarditis was much lower. And this has also become apparent in the UK, where they started going right from the beginning with a 12-week interval in order to spread the vaccines further. They found no increase in myocarditis after Pfizer vaccine amongst the whole population, but amongst under 40s, there was an increase after Pfizer, much greater increase after Moderna, but that's not relevant for us. But they didn't see an increase in pericarditis or arrhythmia. And in pink here, you see the rates of myocarditis after infection. So again, the risk of myocarditis after infection in the UK study was way higher than after the vaccine, the Pfizer vaccine. In the Danish study, the risk of myocarditis after COVID infection was 40 times the risk seen following the vaccine. The myocarditis is generally mild and recovery is fairly quick, but having said that, at 3 months out, half of the patients are saying they have absolutely no symptoms. Of various different symptoms, around a quarter are still reporting them. Things like fatigue and shortness of breath and chest pain. As of November the 20th, we had 277 reports of myocarditis or pericarditis. This is the latest data available, and that was after 7.35 million doses. An in-detailed analysis was done some weeks earlier in October of 118 of our cases, and actually the gender split was higher in women than men a little, and there were more cases after dose 1 than dose 2, but obviously more people would have had dose 1 at that point. So our rate of myocarditis is 7 cases per million after dose 1 and 10 cases per million after dose 2. So that's over the whole population. And in our study, our data, the time between vaccination and first symptoms was generally within 5 days after vaccination. And we have had 2 deaths, very unfortunately, that are likely due to the vaccination, and there is another one being investigated. And other countries such as Australia, who's given nearly 25 million doses of Pfizer, have not reported a death. And Israel has given 10 million doses and reported 1 death and 1 very severe outcome. So moving on to AstraZeneca. So it's our alternative at this time to Pfizer for those who cannot have Pfizer or for those who simply prefer it. It's for over 18 years of age, so that's important to note. And the interval is at least 28 days. UK study data does show that an interval of 8 or more weeks produces better protection. And this isn't available at all vaccine sites, as you know. Here we see Australian active monitoring data again. And just to remind you that the side effects after AstraZeneca are greater after the first dose, unlike the Pfizer vaccine where they're after the second dose. So again, it's a reactogenic vaccine with a sore arm, fatigue, headache, joint pains. And again, these are usually mild and resolve after 1 to 2 days. I thought it was worth noting here that in the adolescents aged 18 to 19 who've had the AstraZeneca, their side effects are quite a lot higher. You can see local sore arm, 57% after the first dose, fatigue, 66%, headache, 64%. So higher rates of these local and systemic adverse events are for younger people compared with the total group. So it's worth alerting people to that if you are giving the vaccine to younger people. The main concern with this vaccine is this thrombosis and thrombocytopenia, an unusual syndrome, which causes very serious blood clots in unusual places, commonly the cerebral blood supply, and also sometimes the abdomen, associated with low platelets. And the main identified risk factor for this is the age, with increasing risk in younger people. So from the Australian data, they report 3 cases per 100,000 under 50 years, 2 in those 50 to 59, and 1 in those over 60. UK data expressed as an overall rate was 1.5 cases per 100,000. And the risk is 10 times lower following the second dose. So it's very much associated with the first dose. So these clots, people can present with these clots between 4 and 28 days after the receipt of a vector vaccine. So the Janssen vaccine in America has been associated with it also. And it's a wide spectrum of severity for this illness, but in some, the clots can be very aggressive and challenging to treat. And I was just reading the slides from a recent ACIP meeting in USA, thinking about the Janssen vaccine, and some people presenting with that died within a day of admission to hospital with these very aggressive clots. And the clots are more likely to be in the cerebral or splanchnic vessels in younger people, and in older adults tend to be less aggressive and in more typical places. So the case fatality rate was high initially, but now Australia has, I think, seen 8 deaths at a 3% mortality rate. The UK reports a 17% mortality rate. And some people may have ongoing problems from their strokes or thrombosis. This is a graphic produced in Australia because with their rate per of the syndrome and then the 3% death rate, they calculate the risk of dying from TTS after AstraZeneca is 1 in a million. And I found this interesting, that the risk of death due to daily aspirin, for example, is 100 in a million, and the risk of being struck by lightning 2 in a million. So that does put it in perspective. I commend to you these 2 MedSafe publications, one for discussion with the consumer and the other is information for healthcare professionals. And of course, we have a lot of information on our website, including a detailed fact sheet. The other possible adverse events after this vaccine include Guillain-Barré syndrome, thrombocytopenia, not associated with thrombosis, and a very, very rare syndrome called capillary leak syndrome. And just to remind you that if somebody is having an AstraZeneca vaccine following an adverse event to a Pfizer, so having a mixed schedule, there is a good study that shows that people who had a Pfizer followed by an AstraZeneca had a higher rate of the systemic adverse events. Here you can see fatigue, headache, malaise, or more frequently reported than after people who have had 2 doses of Pfizer vaccine. So again, this is something to warn patients that they may feel unwell in the day or 2 after the vaccine. So contraindications and precautions for this are important. So obviously, if anyone has had the syndrome of thrombosis and thrombocytopenia after the AstraZeneca, they mustn't have another dose. People who have had a history of cerebral venous sinus thrombosis, this is just, a concern, but a reason not to give them the AstraZeneca. And if somebody has had an episode of heparin-induced thrombocytopenia, which seems to have a similar pathologic process to this TTS seen after the vector vaccines. This heparin-induced thrombocytopenia is not uncommon after major cardiothoracic surgery. Then if somebody's already had idiopathic thrombosis of their vessels in the abdomen, if they've got antiphospholipid syndrome with a history of thrombosis, if they have that rare capillary leak syndrome, if they've had anaphylaxis to previous dose of AstraZeneca or anaphylaxis to any component of the vaccine, and a serious adverse event to a previous dose. So people who have had DVTs in the past, or something that is a clotting tendency that's not immune related, can have the vaccine. People who've had thrombocytopenia, or people on anticoagulation therapy. So there's no evidence that a past history of clots or clotting tendency increases the risk of thrombosis and thrombocytopenia syndrome, but we do have those concerns I listed on the previous slide that make us worry enough to think that it's not a good idea for them to have an AstraZeneca vaccine. So it's a widely used vaccine around the world. It's effective. It has this unusual syndrome. And so it is important to have a good discussion with people before having it. And if they're having it in a mixed schedule, they will have more adverse events, and also if they're young people. So just to touch briefly on the third primary dose for immunocompromised people, these are those who are severely immunocompromised, and it's ideally given at least 8 weeks after their second dose. But in special circumstances, the interval can be reduced if they're about to have some further immunosuppressive therapy. If they're going to be finishing immunosuppression, it might be sensible to delay their third dose so it can be more effective. And if people are on immunosuppression, that can vary if they have a nadir or are able to have a break in their immunosuppression, that would be an ideal time for them to have the vaccine. And the Ministry of Health did broaden the criteria for these, the groups eligible for this vaccine. And so there is an update there on the 25th of November, and they do comment that you can apply clinical judgment. So if somebody a doctor in their primary provider feels they do have severe immunosuppression, then they can have a vaccine, even if it may not be listed. So I'll hand back to Jane now, and I'll stop sharing.
Right, thank you. So my turn to start sharing. Okay, so I'm not going to teach you about consent. You should know that as part of your vaccine training. But what I would say is that it is important that informed consent includes a discussion about the risks and the benefits of the vaccine. And so it must take place before each dose of the vaccine. And I think we are hearing comments coming through that sometimes people assume that because somebody has turned up for a second vaccine, you don't need to maybe go through the risks and benefits of the vaccine with them. There is an assumption they've just come for the vaccine. So we're particularly keen that people just revisit the fact that you do need to talk about, for example, the increased risk of side effects with a second dose, or even with a third dose, with the booster doses. Confirm that they've had the appropriate information. And here I've listed 3 of the newish resources that are available. So you don't have to go through all the details with everybody every time, but it's great to have leaflets available so that people can read them while they're waiting for their vaccine, so that you can check, right, which leaflet have you had a look at? Have you got any questions? Is there anything you don't understand? So the one in the middle there is get simple language, easy language for information around the COVID vaccine. The one on the right-hand side, the colourful one, that's the AstraZeneca one, and the one on the left is the new one around the COVID vaccine. You will notice as well that the wording in them around myocarditis has been updated. So please, please go back to your vaccination sites, get rid of the out-of-date ones, get yourselves the new, latest versions, and make sure that you are using them. Every person should take away written information, as well as having had somebody talk to them about the risks and the benefits of the vaccination, and they do need an opportunity for questions as well. So here's just a few other resources that are available. The one in the middle here is the Tireo. If you have a tablet or even on an iPhone, on a phone, you can play that one for somebody that maybe hasn't got English, somebody that isn't able to read. Unfortunately, there's a lot of Tireo information, but I couldn't find a printoutable Tireo leaflet. So if I've missed it, my apologies. But certainly there's a lot of information on the website that's translated into lots of different language. This is from the Ministry of Health website. There's the sign language one here explaining about the vaccine. The what to expect leaflet that you've been used to using right from square one, that's been updated. And as I say, some other easy read and new resources. So just to be aware that they're available. Now for pre-vaccination screening, we produced guidance ourselves for you. Anyone that's really awake and alert might notice that this is version 8. On our website at the moment, recently gone up as a new version is version 7. Version 8 is due to go up in the next day or so, and the difference is very small. In version 8, we are including children. So this actually includes information for the pediatric doses of the vaccine as well. And they're very, very similar. So it made sense to have one form. My idea is that you keep it in front of you, you'll have it as a reference so that you're always asking the same questions and you've always got the guidance there as to what to do if somebody says yes to those questions, or if you've got somebody's got a question that they want to ask you. On the back page of those resources, there is more information on informed consent and also the basic information that you must be giving out for post-vaccine advice as well. So for this one, it reminds you that a person who has developed myocarditis or pericarditis after an mRNA vaccine should not have any further doses without specialist review or advice. So that's an important question, and we've just reiterating that. If they're 18 or over, it may be appropriate that they have an Astrazeneca vaccine. And we're available to offer support and advice on individual case-by-case basis for people that have had myocarditis, excuse me, or pericarditis following a vaccine. People with a history of myocarditis or pericarditis that's not related to the vaccine can go ahead and have the vaccine after the episode has obviously fully resolved. I notice there's a few questions coming in, and I'll get Joan to address some of them at the end. But just to say at this point, if somebody comes to sit in front of you and says, oh, well, actually, I have had a bit of chest discomfort or a bit of tightness, or I've had a bit of fluttering or palpitations, but it wasn't that bad and I haven't been to see the GP, then we would recommend a longer spacing between vaccines of at least 6 weeks, and that the symptoms should be fully resolved. If the symptoms aren't fully resolved when they come to see you, then I would send them back to their GP as well for a proper review. But if they're saying, oh no, it happened just a couple of days after the vaccine and I'm absolutely fine now, then we would still recommend a space, a longer gap, because as you saw from the charts that Joan was showing, the risk of myocarditis is higher with the second dose, and that is reduced by having a longer gap between vaccines. So if we have people where we have an index of suspicion, nothing evidenced, nothing that really warrants a trip to the GP because it's settled down, but actually let's play it on the safe side. We also have the Astrazeneca screening form, which I've put in a darker orange to match again the top of the Astrazeneca vial. And this here will give you the guidance questions. It also gives you post-vaccination advice and a little bit more information to have to hand around TTS and such like. So try to get all your resources, sort of the key messages that you need, together in one place. So these two are downloadable from our website. The other resources I've talked about are on the Ministry of Health website. And so then just to finish off with the importance that for post-vaccination advice, please, please ensure that you do talk to people about post-vaccine advice after each dose of vaccine, not just assume they remember it from last time. And it should be given in writing as well. So yes, there's this new resource here now, what to do after your COVID vaccine. But those resources I showed you, the colourful slim ones at the beginning, they also have a section at the end about post-vaccine advice. So it's perfectly acceptable to just open that and sort of direct people, this is where the information is. what we're keen to be doing is making sure that people are aware of the risk without making it into too big an issue, but that they do know to call for help and they know when to practical things like booking other doses. So the particular things that we're seeking people to be aware of is they should seek help for any out of character symptoms such as chest pain, but that could also be a heavy feeling in the chest or discomfort. People will describe it differently. Sensation of heart fluttering, racing or skipping beats. Words palpitation doesn't always resonate with people. Any difficulty in breathing, dizziness or fainting. Now I know that is going to flag up a lot of people that haven't got myocarditis, but actually under the circumstances, we just have to be extra cautious. So we're encouraging them not to ignore these symptoms. It's important that they know to seek advice from a doctor or from Healthline. The other bit of advice that we're adding in for post-vaccine advice for Fisa vaccine is just to check whether or not they're insulin dependent diabetics. It makes no difference to them having the vaccine, but it is important that they're aware that their blood sugars may become quite out of kilter for a few days after the vaccination. We've had a few cases where people weren't aware that their blood sugars might become more unstable, so do need to be monitored a little bit more closely than normal. And so, of course, with Astrazeneca vaccine, you give the normal post-vaccination advice about symptom management, calling for help if you're concerned and such like, but also, as Joan mentioned, the importance of flagging up a severe headache that's not relieved by simple painkillers, or that gets worse or feels worse when they lie down or bend over, and also that an unusual headache that may be accompanied with blurred vision, difficulty in speech, weakness or drowsiness. And then the rash, the petechial rash, so the little bruises under the skin. And again, shortness of breath and chest pain, here thinking more around a PE rather than myocarditis, but similar symptoms. And of course, the leg swelling and such like as well. So that concludes the first half of our webinar. And so then I can see we've got quite a few questions. So what I'll do is I'll come out of sharing and then Joan and I will try between us, primarily Joan, I suspect, to respond to your questions. So Joan, if you want to come back on screen, and my colleagues as well, if you want to come back on. Oh, we've got Loretta joined us as well. Welcome, Loretta. That's our director. Right, so we can't see people with raised hands. So if you want to ask a question, please pop them into the Q&A box and we will get round to you in a moment or two. So who wants to start reading out some questions?
So you've got one that you were going to answer, Jane, regarding aspiration.
Okay, so slightly off tangent, but it is quite a topical question. We've actually put some information on our website around aspiration. There was a study done with mice whereby they vaccinated them, injected them into the veins in their tails using, was it 50 times or 100 times the dose of mRNA vaccine? 500. 500. Thank you. I knew it was a ridiculously large amount. And they did develop symptoms of myocarditis. So the extrapolation from that some people have made is that perhaps if you inject the vaccine into the blood vessels, this might be why we're seeing myocarditis. There's actually no evidence to support that. And the best practice of vaccination is that you don't aspirate, because aspiration, which is basically when you put the syringe in, the needle in, and then you pull back on the plunger a little bit to check that you're not in a blood vessel. Doing that is actually more uncomfortable. You wiggle the needle around a little bit unintentionally, prolongs the vaccination process, and has been something that the World Health Organization have said for many years now is not recommended when vaccinating into the deltoid, because you don't have major blood vessels in there, so you're not going to risk injecting into a major blood vessel. So although this one little study has been picked up on by a few people, it's something that other countries are not changing their practice around vaccination on either. So for the moment, we're very much a case of if somebody will only have a vaccine if you aspirate because they've read this study, absolutely no harm in doing that. Feel free. It'll do them no harm. It might make the injection slightly more uncomfortable and take a little bit longer, but we're not changing our best practice based on one little study of a few mice and 500 times the dose. I don't know, Joan, if you want to add anything else to that.
No, I think you've covered it. Yeah.
Okay, thanks.
Joan, next question for you. A young man developed PE after his first dose of Pfizer, fully investigated, no prior condition. How would you advise him?
There's no evidence of increased risk of thromboembolism such as PEs after Pfizer. So I would leave have a decent interval and make sure he's fully recovered, but he could proceed. But that's the sort of question that's better to send a question to us on the 0800 line than to do in a public forum, really.
Agreed. And I think you have to imagine we've had, 4 million people vaccinated. We will get odd things like this that are coincidental that occur. If we look at the number of PEs that people have generally within a year, they're not going to stop just because we're doing the vaccine. So there's always that, is it coincidental or could it be linked? But certainly we can give advice on the 0800 line.
And possibly need more history around that as well.
Yes.
Joan, we've got another question for you here. How does the histology from post-mRNA myocarditis compare with the histology in post-SARS-CoV-2 myocarditis?
Well, I've read more about the vaccine-associated myocarditis, which is an inflammatory infiltrate, sometimes with eosinophils. And I'm sorry, I don't know what the viral-induced myocarditis looks like. I know it's much more severe. It's a serious, really serious condition when people get myocarditis with COVID. I haven't seen post-mortem studies, I'm sorry, of that condition though. But I'm happy to look it up and we can get back to that person.
There's a few questions that are sort of around this theme. So what about those that have had chest pain but negative tests, or have had symptoms of myocarditis but haven't reported them? What's the recommendation for those people?
Those who have had symptoms and not have them investigated are concerning and difficult. If people have had investigations at the right time with ECGs and troponins and C-reactive protein, and their symptoms have settled down, that is reassuring that they haven't had myocarditis. It's harder to exclude pericarditis, but myocarditis is more concerning. Those who haven't been investigated, if they have ongoing symptoms, we would want them to get investigated before they have another dose. If somebody had symptoms after the vaccine that lasted a very short time and they weren't concerned about it and it settled down and they've had no further problems, it is probably all right to have another dose. But it's much better if people do get seen when they have symptoms, and that is the message we're trying to encourage you to remind people. So hopefully those that have had symptoms and not been investigated will diminish.
Thanks, Joan. Another one on the same sort of line, but wanting to know if we have any data yet on the rates of myocarditis in the 5 to 11-year-old group?
Well, the US data to date has been very reassuring around that, yes. And typically with other causes of myocarditis, viruses commonly cause myocarditis. It's adolescents that have a much higher rate than under 12-year-olds in general for myocarditis. And at this point, the data from USA is reassuring. They haven't had so many second doses given yet. They've had a lot of first doses, but the data has been collected and looked at. It's another advantage of us being, not the leading light like America is. And one question I saw asked about the rate from my New Zealand data slide. That was the rate calculated by that report on myocarditis by MedSafe when they'd had 118 cases and 6.3 million doses. So not the top line, which was November's rate and a larger number of cases of reports.
Someone here's asked, are there any particular common risk factors in a younger age group that may predispose them to experiencing myopericarditis after receiving the Pfizer vaccine?
Well, as I just alluded to, they are the age group that typically has higher rates of myocarditis, you know, from other causes. So
There's
whatever
no other
that reason is, and it's more common in more common in males than females. Yeah. Sorry, Jane.
I was going to say there's no other criteria that we're aware of, obesity or anything like that, or vigorous exercise doesn't seem to play a part that's been flagged so far, if that's what they're asking.
The main factor that I can find is the interval between doses. That's something that's just recently been shown.
The next question is, the CDC is advising against any subsequent COVID vaccination in those with mRNA-associated myocarditis, including subsequent viral vector vaccines. This contrasts with the Australasian guidelines. Do we have a more relaxed medico-legal environment? Question mark.
Well, I don't know that it's anything to do with the medico-legal environment. We've got this guideline, you know, that the Australasian College of Cardiologists made in conjunction with ATAGI and that in Australia. If you read the CDC guidance carefully, they say that people can proceed to vaccination after discussion with their cardiologists and the individual, a careful discussion. So it's not a blanket, don't have another dose. And we've got the very clear guidelines from ATAGI and the College of Cardiologists that, you know, have a flow chart for pericarditis, whether it's proven or whether investigations have not been done. And it's, you know, we use it at IMAC to guide us, and we meet with 2 cardiologists to try and give the best advice for an individual. So nothing is cut and dried. It's something that's all a weighing up of the risks and discussion.
And the benefits and risks of using Astrazeneca as an alternative vaccine as well comes into play with that one, doesn't it?
Yes, it does, yes, which is less, you know, it's not an alternative for under 18s. No. And, you know, it's something to be very carefully considered for young people. The Astrazeneca is an alternative.
Okay. I'm just looking at some of the other ones. Do we need to get written confirmation from a GP or specialist that a person has been assessed as medically fit to receive the next vaccination after having had cardiac symptoms? Or do we work on the high trust model and take their word for it? I think New Zealand has worked on a high trust model with this vaccination program right from square one in terms of people self-identifying who they are and not having to bring identification with them. I think vaccinators should trust their own intuition and their own judgment would be my guess on that. And I would think most people, if they've actually been investigated by a GP, would want to have information and be, you know, would be very cautious about rushing in to have a vaccine if it was actually against guidance. If Joan wants to add anything to that.
Unlikely that they'd be wanting it if they'd been told not to.
Question here around, should patients be advised not to exercise vigorously after Pfizer vaccine? In Singapore, the advice is to avoid exercise for 2 weeks post-vaccine.
That is something that we've actually added into our screening tool. I meant to mention it. We are saying if people are feeling unwell after the vaccine, then don't take vigorous exercise. So we have included that. We don't make a big song and dance about it. And certainly if they're feeling fit and well, we don't particularly mention it. But if they're feeling under the weather, feeling tired or whatever, don't push it. So certainly wouldn't go out and run a marathon a day or 2 after a vaccine.
So I don't think there's any strong basis for the Singapore recommendation, but we have noted it. And as I say, as Jane said, yeah, we'd encourage people to listen to their bodies.
Someone's asked here around what investigations at a GP level should be done when a patient experiences chest tightness, palpitations post the vaccine.
Well, there's very good guidelines available in ECG and troponin and C-reactive protein, and one assessment may not be adequate because it can be an evolving picture, so they might need to have a reassessment in 24 or 48 hours depending on their symptoms. And I think the big thing is to encourage people to seek care if they are having symptoms.
There's a quick question here. What's the average recovery time for vaccine-induced myocarditis or pericarditis?
Well, as I showed at 3 months, 50% are completely recovered, and a variety of symptoms are still felt by about 25%. There's good, I had a slide in, but I took it out, showing that the ejection fraction recovery was actually very quick in most people, well, in the group that had, it was a small group from America, but they'd had echo follow-up, and the ejection fractions recovered very quickly, much quicker than myocarditis, usual myocarditis from other causes. People are in hospital a very short time, usually with this vaccine-induced myocarditis.
A couple of quick ones. When we'll be giving boosters to 12 to 18-year-olds, we've no idea on that one at the moment. We'll be watching for the data, but it's not in the near future as currently anticipated. Will there be funding for GP appointments related to COVID vaccine side effects? I think ACC covers vaccine side effects, doesn't it, Joan? So that should cover GP's appointments, wouldn't it?
If it's accepted by ACC, yes.
Yeah, that's the issue.
So we'd encourage. I mean, we're hearing the difficulties faced by patients and GPs, and encourage people to apply for ACC for consideration of cover for ongoing symptoms.
And there's a couple here mentioning exemptions, and really just to say that our role is we offer advice, but we're not involved in any decisions around whether somebody gets an exemption, although we do act as advocates for people that have had ongoing symptoms.
Question here, if someone had myocarditis from Pfizer and goes on to have Astrazeneca, oh sorry, it's just disappeared. Has there been any cases of heart problems after it?
No, that would be small numbers of people to date.
Next one, there's been a lot of fear for cardiac patients at the moment to keep getting booster shots every 6 months. How would we advise them or reassure them?
We don't know whether. I was going to say we don't know whether the booster doses will be needed every 6 months, and because you're a cardiac patient doesn't mean you should be at a particularly higher risk of getting myocarditis post-vaccination anyway.
I mean, you're at risk of severe illness from COVID in general, but
yeah.
But I think we don't know yet. Things are, as everyone knows, this is a rapidly changing field, so we're not sure about future boosters. We're only just talking about our first boosters, so.
And yes, I can relate to the person who's written the question in around, should these people get vaccine exemptions if they've had serious problems following a first dose of vaccine? And we do understand that people would be wary of wanting further doses of vaccine. And as I say, we do act as advocates, but we're not the ones that are part of the actual exemption process. Right, how are we doing time-wise? We've got another 10 minutes, so we can do a few more. So you certainly can understand people's hesitancy around having further doses. But with support, and depending on what the problem was, a lot of people are going forward and having second doses of vaccine.
Another question, any issues with myocarditis with boosters with the Pfizer vaccination?
I haven't seen any data on that yet, no. I think it's reassuring.
I think the data on boosters is that it's very similar side effect profile to the second dose, isn't it?
Yes.
but it is, yeah, I mean, it's early days for us with booster doses, but I'm sure there's a lot more data being collected globally. So why would a patient who developed myocarditis post-vaccine and had a history of the disease in the past be denied a vaccine passport? I think you're talking about exemptions, and there again, that's not our place to be making comments on. But if they've got a good case, we're obviously amenable to supporting it if we feel they have got a good case.
And it doesn't seem that people with previous but completely settled myocarditis or pericarditis are at increased risk. They can be vaccinated if that is all settled, their previous episode. In fact, in the Danish paper, no one with none of their cases that had myocarditis or pericarditis after the vaccine had a history of myocarditis or pericarditis. So they're probably two different pathologies. But you certainly wouldn't want to vaccinate anyone with active myocarditis or pericarditis from a different cause, obviously.
Just responding to a question on children's vaccines. As I say, we're not covering children's vaccines today, but the online training will be available at the end of the week. And we will be doing a webinar early in the new year on that one.
Question here, any information on menstrual issues around I presume that's around post-vaccination?
That seems to have been noted after a variety of the vaccines, not any one vaccine in particular. And it's probably more to do with the systemic reactogenicity after the vaccine rather than any component of the vaccine. And numerous bodies in the UK and etc. have looked into this and don't see any serious persisting problems. So it's been put down to just the reaction to the vaccines themselves rather than anything in one or other vaccine.
So there's a question here, just a nice simple one. If anybody wants to access this recording, it will be on our website. It might take us a day or two to load, but certainly by the end of the week, it will be available on our website under the under our webinars, the link for webinars. So there's a range of resources on there.
There's just a question here, Joan, around what process is followed when there's been a death that's reported and determined, and how is that process? Would you like to talk a little bit about the process that happens?
Well, the Centre for Adverse Events Reporting follow up with all deaths and get as much information as possible. It sometimes is difficult if they haven't, if there was no post-mortem and no one thought about the vaccine. Sometimes information isn't forthcoming, but once all the information has been gathered, then all these are looked at carefully by MedSafe and the Independent Safety Board, ISMB, Independent Safety Board monitoring, that look at all the available information. And unfortunately, sometimes there isn't much information available in some circumstances. And obviously, all deaths that are unexpected should be going to the coroner as well. So that is a very thorough process, but it is slow. So preliminary information is what the ISMB has to work with and CALM, and each one is carefully scrutinised as much as possible. And just to remember, we expect 90 deaths a day in New Zealand from all causes.
Yes, that does put it into context, doesn't it? So there's a question here, is there going to be more data made available to the public? This is coming from a paramedic who works on the clinical desk. And there will be more calls going through, but part of that is because, yes, there is more information to the public around the risk of myocarditis post-vaccination. At least that's dependent on you guys that are listening, promoting the message for us, because obviously it relies on vaccinators, but also on the leaflets. But the information has been thought through quite carefully, and it is a targeted time period post-vaccination. It's not ongoing. So hopefully it won't increase the workload too much, and we will just get actually better information out to the public, because they should be flagging up if they've got chest pain, if they've got unusual palpitations or something, whatever, they've had a vaccine or not, they should be seeking guidance. And particularly with the males of this males of the world, the younger males that are fit and healthy, they often don't flag up problems when maybe they should, as we know.
Joan, there's a common question here that comes up, so it's probably a good one to ask. Is there any benefit to having an Astrazeneca booster when I've already had Pfizer as the primary course?
Sorry, it cut out a little. Any evidence in what, sorry?
Of having AstraZeneca as the booster when they've had Pfizer as a primary course.
No, Pfizer would be is the preferred booster. Studies have looked at that, a UK study. So I wouldn't mix and match unnecessarily.
There's also a couple of questions, Joan, around are there new vaccines looking at being developed for the with now the Omicron?
Yes,
strain?
Pfizer. Yes, we're staying off on Omicron, but Pfizer is now looking at a specific vaccine tailored with the spike protein to accommodate the spike protein mutations. It all going well, it would be available by March, they hope. So it's a very rapidly evolving area.
And someone's just asked, what if they have AstraZeneca first, then Pfizer?
If you've had 2 AstraZeneca overseas and want a booster, the better booster is probably Pfizer immunologically. It's the preferred booster in the UK.
Is it safe to have Pfizer then, is the question that's come up. Well, I think it's still one of the safest vaccines out there, isn't it, in terms of most efficient and most effective vaccine. We've been particularly unfortunate, but putting it into context with the number of people that have died from COVID disease, even with the small number of cases that we've had, I think it has actually got a good safety profile. And one of the things with myocarditis is if people do flag up the symptoms, generally, if they're being observed and treated in hospital, then there is treatments that can happen. It's if they collapse and they're not in a place where they can get help, they're much more likely to have a death as an outcome.
And we have certainly been seeing the effectiveness of this vaccine since our Delta hit and had our outbreak in Auckland. We would have had a very different curve were it not for the very good vaccination coverage that we now have.
Right, well, numbers are getting down. How's our time doing? We've got time for probably 2 more questions, so let's pick out the most relevant ones. Pretty much there. Jane has mentioned vaccines to fight new virus may be available in March. That's not this Jane, I have mentioned. So maybe
the variant,
but the variant. Yeah, apologies. Yeah. Just reading that question, answering questions and listening at the same time. My apologies. Are there any long-term sequelae from myocarditis? Can people be more likely to develop arrhythmias down the track?
Well, it's hard to say very long-term outcomes, but it seems to be reassuring outcomes at this stage with rapid recovery generally.
Good. And so let's just go for one last one. We've talked about that one. If somebody's had AstraZeneca and then had 2 Pfizer vaccines, does he need a booster dose? If he's already had 3 doses, vaccines are sort of interchangeable, much as we'd prefer you kept the same vaccines. But certainly if somebody didn't disclose they'd had 2 AstraZeneca and then went in and had a Pfizer dose, that would be counted as a 3rd dose. I mean, obviously to get booster properties, you really want a 6-month gap or at least a 4-month gap, but we certainly wouldn't recommend keep giving new doses of vaccines just because it's a different brand.
No.
Right, I think we will call it a night. It's 6 o'clock. We've covered just about all of the questions and certainly all the ones that were totally relevant to the presentation. So thank you all for joining us, and I wish you a pleasant evening, and keep up the excellent work on the vaccination programme. You're all doing a fantastic job out there, and we wish you all a happy Christmas.
Yes.
Let's hope we manage to have some quiet time over Christmas. Bye-bye, everyone.